Good morning, good afternoon, good evening, wherever you are. This is Firoz Manchi from Daraja Press. Welcome to Organizing in the Time of COVID-19. My guest today is the amazing Salima Valiani, poet, intellectual, mother, and activist. Salima is author of uh, Rethink. I must get this up on my screen. I've been dying to get this up here. Um, what's happened? There we are. Oh, Rethinking Unequal Exchange, the global integration of nursing labor markets, which traces the structural forces that have created the conditions for the increasing use, production, and circulation of temporary migrant nurses worldwide. She's also a prolific producer of research and policy papers on health and healthcare. And she has worked as a researcher with unions in Canada, the Philippines, and South Africa since way back in 2005. She's also an outstanding poet, having published several books of poems, including Breathing and Breath, Land of the Sky, and Cradles, which was published by ourselves at the Raja Press. I want to give a very warm welcome to friend and comrade Salima. Welcome to the show, Salima.
Thank you. Thanks,
It,
Firoz.
it's great to have you here. And today I'd really like to interrogate you and to have a conversation with you about um, the extent to which COVID-19 has exposed uh, the particular nature of capital, but also the crisis of capitalist healthcare. So tell me, I mean, how do you see this manifesting itself within the health sector?
So I like to think about it as the crisis of capitalist health bracket care. And this crisis has been ongoing for a few decades, but the pandemic has allowed us to see it in much more clear view. Now, there's many different aspects of this crisis of health bracket care. The first, I'll start with the more obvious ones coming out with COVID-19. So the first of the very obvious ones is, of course, the underfunding of public health care. Now, that has been a pattern in most places in the world since about the 1970s. And as you said, Firoz, this means we also end up talking about the crisis of capital. And from around that time, the 1970s, there was a major shift in what capitalists were interested in doing, what they had been doing for the decades before, and how states went along with the change of mind of some of these big, powerful multinationals, which came into being, of course, long before the 1970. They came into being from the beginning of the 20th century. So one of the shifts was that healthcare is too costly. And so we cannot spend public funds on public healthcare. Now, this took shape in different ways in different parts of the world. So in a country like South Africa, relatively rich in the African context, but only independent, quote unquote, from its colonizing powers since 1994, what this notion of public health care being too costly, unaffordable, has meant that as per government spending, healthcare has been about hovering around 8 to 10% of all government spending on social programs. Now, this is in opposition to what African governments committed to in 2001 when the HIV epidemic was looming large. There they committed to 15% of government spending for healthcare. So South Africa, as a rich country, has been hovering at about half of that since 1994.
But isn't it true that, I mean, this is a reflection of the structural adjustment programs, the privatization of whatever was available in the commons for profit? But I think one important point, because when you say 8 to 10%, that's the proportion of the total budget. But at the same time, taxation has been reduced from the rich and from the corporations. And so the actual effect, isn't it much larger than that?
So the reduced taxation on corporations and rich individuals, right, which are even richer than corporations, is another aspect of the changes we've seen worldwide since about the 1970s. And African countries are included there, whether or not they had to undergo structural adjustment through loans taken from international financial institutions. So a country like South Africa has never had structural adjustment due to loans and conditions from the IMF, World Bank, and so on. But yes, the state decided we will not be spending on the people. We will be taxing the rich less. And 4 decades later, we see the outcome of that when we try to deal with a pandemic like this particular coronavirus. Now, another aspect of this crisis is the commodification of medication and machines and health related, right? So what we see is that there aren't enough tests to check for the coronavirus. There aren't enough chemicals available to actually read the tests. Why is that? Why are they in such short supply? Because we've allowed corporations, and it is a handful of corporations, as I show in my book, that control the production of all of this technology, from the tests to the ventilators to the protective gear for healthcare workers. Then there's the medicines, and we saw global activism around making HIV medicines accessible because they were dominated by a few corporations producing them. Again, this is a crisis that has been part of our lives for several decades, and this pandemic brings it out. But what I show in my book as well is that this is a systemic problem. So the large corporations dominating medications and medical technology is not unlike the monopoly of production in other spheres, like food. So commodified food production is another part of the health crisis in a couple of ways. So culturally, in many parts of the world, let's say, not all of them, thank God, there's still a lot of hope. Food is disconnected from health. We don't conceive of what we put in our bodies as related to the health of the body. And this goes from the average person all the way to medical professionals. Now you take the Chinese medicine system, in contrast, the two are very related. You take the Indian system, the Ayurvedic system. What you consume is very linked to the kind of health that you enjoy. The other aspect of commodified food production is the loss of biodiversity, the environmental destruction, which I think you've covered in these interviews. And of course, that exposes us to more viruses, like the coronavirus. If I can talk also about the disconnect between. Are you still there?
I'm still here.
Oh, okay. I just lost it.
Yeah.
There's been a disconnect between health and safety and work. And we see this through the pandemic coming out, especially when we look at nurses, other healthcare workers whose safety at work is not respected, even during the pandemic.
Mm-hmm.
So we don't afford them the equipment they need to perform their work. And we see it, another very stark example to me is around migrant food workers. The way that we do not respect their health, their living conditions.
So can you explain who you mean by migrant food
So
workers?
let's take the farm workers in many countries, from Canada to Italy. What's happening is that on the one hand, we need their labor to harvest the food that we depend on, especially now. But we do not assure them safe working conditions, safe living conditions. I was just looking today at a video of the way that migrant farm workers are being accommodated at this moment in Canada. They're sleeping on crates that are separated by about 1.5 meters with a mattress on them. That's supposed to be the social distancing for migrant farm workers. Some countries have blocked those workers from being able to come and work. So they have a problem harvesting food in those countries. So this is the disconnect between health and safety, work, and again, food. We also have the culture of the quick fix. So as individuals, we've become less interested in actually keeping healthy, leading healthy lives, well-rounded lives. We would rather go for the quick medicines and other fixes that commodified medicine offer us. And then one more would be that health has been individualized and care taken for granted. And what we've seen in this pandemic is that actually health is collective. It's a collective concern. It's a collective project, takes collective energy, and care is crucial to that effort.
So tell me more about the impact on labor, on especially in the health sector. Many of these countries, not merely migrant labor which works on farms, it is also migrant labor. One of the points that your book makes exceptionally clear is the extent to which the reproduction of critical labor in the health sector is actually generated outside of the capitalist countries. Isn't that right?
So in the richer countries, I would say, I think all countries today in our world are capitalist, whether they look like the US or England or not. And what we can see in the health labor markets from at least the 1950s is that workers, health workers, I look at nurses, you can look at it through doctors, you can look at it through pharmacists as well. The bulk of that labor is actually generated in poorer countries. And if we think of the world of countries as a hierarchy, there is movement within that hierarchy of health workers from poorer to richer, richer to richer, richer to richest, with the US being the biggest receiver of migrant health workers worldwide. Now, this is a function of a few things. One is that, of course, the majority of the world's population, which means labor, is in the global south. And so through the prism of health, the health labor market, you see what we see in the world economy, which is that the majority of the world, the global south, Africa, Asia, Latin America, summarized in different ways, sustain the very rich countries, the core, as some people call it, North America and Western Europe. So with this migration of workers, you have diminishing rights of workers as well, particularly, as I show in the book, since the 1990s, when health workers and other highly skilled workers, rather than coming into the very rich countries, Canada, the US, Britain, Australia, so on, as permanent migrants with full rights, they have been coming in on the temporary work permits with lesser rights, including less pay, difficult working conditions relative to the local workers, and the lack of the right to residency. So workers can't bring their families. Their families can't benefit from the better salaries that they're earning. Those remittances then go back home. The salaries go back home. So this is, again, a changing structure in the world economy. We can trace it from about the 1980s onward, different sectors, but health was one of the first. And
so
the
what
change continues.
So what does COVID reveal about this?
So when we look at reveals many things, but I mean, you look at England, for example, some of the first medical professionals, doctors, nurses, to die from COVID were racialized workers from the global south. And that has to do with a few things, right? It has to do with those lesser working and living conditions that migrant workers face. But it also has to do with the fact that they are, as individuals, relatively less healthy, given the difficult work and life conditions that are typical for them, to their being in this world. So they become more vulnerable to epidemics and pandemics like this one. And also they are likely working more or in worse conditions than their colleagues who are locally based or have full citizenship rights.
But isn't it also true that it's a lack of personal protective equipment? That's one of the things that seems to be revealed in both the US and Canada, in the UK and Europe, that these are particularly the people who don't have adequate mask, adequate coverage, adequate protection against the exposure, which they have a very intense exposure to. Isn't that right?
Well, I mean, I think medical workers generally are not getting the protective gear they need. And that goes back to the earlier story I was talking about, where such fundamental goods are produced by a handful of corporations that do not produce enough because they aren't producing as per need. They're producing as per what they can make the best money from. So if you have a less supply than what you need, then yes, the racialized, the migrants, the minorities, they're going to be the last on the list to get the equipment.
So let's turn to South Africa, and here you have you've argued a depleted health budget, a depleted investment in health care. But isn't it true that the policies of the government appear to be centered more around the use of coercion than about investment in the health sector. Isn't it not true that force is being used to separate out the impoverished from the elites? That this is another new form of apartheid?
I think the definitely force has become a major thrust rather than care, as I said recently in a poem, actually. But I think it's a little bit hazier than what we might think, because in a sense, what I feel is happening in South Africa, which is where I live now, is that the state, as a representative of the entire elite, is recognizing actually how vulnerable the majority of the people are to this illness. And the vulnerability goes deep. It has to do with at least 100 years of poor living conditions for the majority, of underemployment. Where people are employed, it's in very unsafe and difficult, stressful conditions. So the state has realized that people are vulnerable to catching this coronavirus. And because the state has not facilitated good housing, good jobs, good public transport for the majority, it has to now resort to violence to try and control people. Because people don't have the means or even the understanding necessarily that we need to distance. We need to wear masks. So this is inevitable. Unfortunately, it as I was saying, I think the way that capitalist society really works, the ideas on which it is based are coming out now. And that's what we see currently in South Africa.
But for people like the shack dwellers that are organized by Abaklali across South Africa.
Sorry.
Oh, that's okay.
Not COVID.
I hope not.
But it started at the same time as the lockdown.
Oh, sorry, Paul. But isn't it the case that people who live in these shacks, the vast majority of the population, have no access to water, have no jobs, and therefore even buying masks is a myth. But secondly, the conditions under which they live, there is no realistic possibility of 2-meter distancing. I mean, it's not a question of whether they understand it or not. They don't have a choice, surely.
So there's people that live in informal settlements, but the majority of the impoverished actually live in townships, which are a bit better than informal settlements. There may be access to water, but there isn't space there. So yes, distancing is not possible. But also, what I'm arguing is that the understanding that there are things that we can do. Okay, we get a certain grant from government. It's a pittance, but we can use it a little bit differently during this pandemic to protect ourselves. That notion of health and collective health is not there. You know, it has not been cultivated. And you can't start in the middle of a pandemic to cultivate it. So we see the moving in of the army in my partner's hometown, because nothing else will force people to stay in their houses, which they do have, but they choose not to stay in. the same thing goes, if I can say, with trying to pump up the health system in the middle of the pandemic, which is what is happening here in South Africa. So it's coming clear now that the very strict lockdown that we had was less about bringing down the vulnerability of people to the pandemic and more about trying to shore up the health system to be able to handle all of the very difficult cases that are now forming of people testing positive for COVID-19. This is why, for example, in the past, the World Health Organization had certain measures of nurses needed per population, because it is crucial to have those health workers in place in case a pandemic occurs, in case an epidemic arises. We haven't listened to any of that. South Africa is one of the worst examples because it actually could have had the resources to do so. And so we're scrambling now. And the violence that you're talking about in informal settlements can be seen in the hospitals, for example, in a different form, where nurses are told, don't use the protective gear now, save it for when the pandemic hits an even higher number of people. It's absurd. It's absurd, but it is a reflection of the way that society has normally been functioning.
Yeah. One of the things I said in the introduction to you is that you are also a commensurate poet, and I understand that over this recent period of the pandemic, you've also written some poems. Might I be able to persuade you to read some of those to us? I think it would give us great pleasure.
Okay, so I wasn't sure which ones to choose, but I think coming out of our conversation, let me choose this one, which came out mid-March on Praxis magazine online. Do have a look at their site. Some amazing poetry from Africa and elsewhere. On Love 39. I begin nestled in fluid cord organs, then skin and chests and breasts. I keep coming for limbs, lips, and cheeks, and when I'm full blown, I still need shoulders, hands, and ears. My heart beats in yours, even if no one hears, even if this appears only through things bought and sold. When I am told to self-quarantine, I will find my accordion, my tambourine, and play for you from my balcony. I will sing with you from my window. I will walk to your home, SMS you to come out and chat from 2 meters. I will forego my work and play with you. I will find a way to give in a world built and crumbling from taking.
Wow. Wow. That's wonderful. One more poem?
Yes, I'd like to do one more, which is called Switch, also recently published on Praxis magazine. Switch. 1. Life matters after all. 2. But some lives are always expendable. 1. Health is a collective concern. 3. But force trumps care. 15. No market without the majority, but individuals are ever invisible. 22. The present is real. Just a hitch in the road to the future. 25. The virus reminds of the power of life that is not human, but domination remains determinant. Ibn Sina, in a poem, taught of Al-Arba Iniya. 40. Quarantina, translated by Italian merchants. 40 days in the 11th century are not even 30 in the 21st.
Wow, as we would say.
Thank you.
Thank you so much, Salima, for joining us on this show. It's been great to have you with us, and thank you also for reading your great poems. Those who may be interested will know that we have on our the Daraja Press website copies of Cradle's poems by Salima Valiani. And it is worth exploring those. Salima, are you planning to bring together further books of your poetry, especially in relation to COVID?
Well, there's a book that has been ready for some months now, which is called 29 Leads to Love. And you heard one of the On Love poems just now. That book brings together all of my various poems, defining and redefining this larger type of love. And so when it was completed, it had 29 on love poems, but now I'm up to 40. So the book is growing because the need, I think, is that much greater. And the need, I mean, is the need that we have globally for a new way of relating to each other collectively and individually. So that's the next one coming up.
Great,
I hope
great.
soon.
Well, thank you so much for joining us on this show, Salima. I really appreciate you giving your time and for reading your poetry. I look forward to being in touch with you again soon. And
Thanks
please
for the
take care.
conversation. And you too, Firoz, take care and don't work too hard. Remember your health during the pandemic. You're doing a
Oh,
great
thank
job.
you. Thank you. But this is play. This is not work. So,
Thank you.
okay, many thanks, and take care. We'll be in touch again soon.
All the best.
Bye. Thank you. That was Salima Valiani speaking to us about the crisis of capitalist healthcare unmasked by COVID-19 and shared some of her more recent poems. I'd like to thank you for joining us today on Organizing in the Time of COVID-19. This is Firoz Manji from Daraja Press signing off.